Urodynamics in females. Stresses on female need extremely careful interpretation, and there are several challenges. The challenge number one is to find out the precise mechanism of urinary incontinence. Challenge number two is to diagnosis of outlet obstruction, and challenge number three is to quantify the detrusor function in all these cases. In addition to that, some neurogenic problems in females can also add complications in interpretation. Let us take a few examples and see how this can be simplified. This 42-year-old woman presented with symptoms of increased urinary frequency day and night, urgency incontinence for the past 8 months. Her symptoms are relatively recent onset. She has no history of enuresis. There are no symptoms suggesting a neurologic disease. She had 3 full-term normal deliveries, no menstrual symptoms. What is the natural urofree showed? There are no physical signs suggestive of a neurologic disease, but there was a mild anterior vaginal wall prolapse. Bladder diary showed small volume frequent voids, classical of OAB. So what were urodynamic questions? The questions were, what is the genesis of her OAB symptoms? Does she have detrusor overactivity? And thirdly, is there a voiding dysfunction? So in this case, we did a uroflow, and you can see in fact, she's a super voider. 50 mL per second is the peak flow, but over a voided volume of 298 mL, which is perfectly fine. Let us see what the pressure flow showed. Yeah, a quick orientation, infusion volume, then comes the intravesical pressure, rectal abdominal pressure, subtracted detrusor pressure. This is the flow rate during voiding. This is the voided volume, and that's the EMG. Now let's look at her. The quality check also shows there's a perfect subtraction and a perfect recording in all the entire graph. So this graph is a fairly good quality for our interpretation. As you start filling at a rate of about 30 mL per minute, you find that there is a very, very mild activity. In fact, it can be labeled as detrusor overactivity, but without producing any symptoms. But yes, asymptomatic detrusor overactivity going to the full volume of 353 mL and the end filling pressure 8 centimeters. So this is mild detrusor overactivity, which is essentially asymptomatic. Sensations are normal, compliance is normal, and capacity is normal. When it comes to voiding, and before the voiding begins, we have asked her to give a deep and loud cough so that we will be able to demonstrate stress urinary incontinence, but no such incontinence was demonstrated, and the pressure had gone up to 116 centimeters of water. When it comes to voiding, that's the change in position. Now she is sitting, that's why the pressure changes. There is no change in detrusor pressure. And as we come to interpret the voiding cycle, you find that that's a straining, and you see it begins at a rate of 15 mL per 15 centimeters of water. A Qmax reaches 33 mL per second, and a P date of 28. So this is generally a fairly normal female void, and this confirms that your recording of the transducers, the pressure lines are intact. So a normal female void produces a fairly high flow at a relatively low pressure and a complete voiding without the residue. So the conclusion in this case are filling and voiding parameters are entirely within normal limits except for very mild demonstrable detrusor overactivity on provocation. This may explain her presenting symptoms of increased urinary frequency, urgency, and incontinence, but neither incontinence nor urgency was demonstrable during the study. Bladder outlet is not obstructed. This may be regarded as primary detrusor overactivity, which becomes more symptomatic during the normal daily activities. Now, this 44-year-old woman presented with urinary incontinence on coughing and on all physical movements for the past 2 years. She has had two full-term normal deliveries. Physical examination showed intact sacral reflex arc. She has mild pelvic organ prolapse and patulous urethral opening. So urodynamic questions are: what is the genesis of a urinary incontinence, and is there detrusor overactivity, and is this a mixed incontinence? So we now look at her urodynamic traces. So this was her Euroflow. She had a peak flow of 29 ml per second over a water volume of 478 and had a minimal residue of 8 ml. When we go to her pressure flow, you find that the quality check seems to be okay. We will move ahead with the two detrusor pressure. Her filling is fairly stable throughout the filling phase. She had a total capacity of 451 ml, but when we tried to check for incontinence, the abdominal leak point pressure should be as high as about 131 here. In the next phase, the abdominal leak point pressure is measured again, and that now happens to be 139 centimeters. So she has a fairly high abdominal leak point pressure, and when it comes to voiding, she begins the voiding at a pressure of 26 centimeters. Voiding proceeds around the same line, and she had a peak flow of 25 ml per second. She voided a total amount of 502, which is a complete voiding with a fairly low voiding pressure. So the voiding is completely normal. So this is a woman who has stress urinary incontinence, but as a definition of stress incontinence goes, what definition says is that incontinence must be objectively demonstrable, and we can actually, markers will tell you the incontinence was seen at the urethral opening, although not recorded on the uroflowmeter. It wasn't severe enough to induce a recording in uroflowmeter, but it was good enough to be demonstrated at the urethral opening. So she had objectively demonstrable incontinence, which must occur in the presence of increased abdominal pressure, and there should be no detrusor pressure rise during this. So this particular finding qualifies for the state diagnosis of stress urinary incontinence, and the same thing is kind of represented here. Abdominal pressure rise, not much rise in detrusor pressure, but this is a pure stress urinary incontinence which has a high abdominal leak point pressure. So it only tells us that the, the sphincter function of this woman is normal. There is no significant RSD, and she has a normal voiding pattern. So in conclusion, I find that we say that storage parameters are within normal limits. The study confirms a moderate degree pure stress urinary incontinence and is mainly due to urethral hypermobility. High abdominal leak point pressure indicates fairly good intrinsic sphincter activity. There is no detrusor overactivity despite provocation. Voiding parameters are within normal limits, and this is a complete conclusion of this urodynamic evaluation. As against that, let us look at this elderly woman who also had the similar symptoms, but she was rather old and she had patulous urethral opening. When we did her uroflow, she had a normal uroflow with Qmax of 25 ml per second and water volume of 444 with a mild residue. When it comes to pressure flow study, as compared to the last case, you find that incontinence was elicited at the volume of 226 ml, and you find here the leakage occurs at a fairly low abdominal pressure of 61 centimeters. Similarly, on the second attempt, we again tried to elicit the abdominal pressure leakage, and that seems to be as low as 55 centimeters of water. When it comes to voiding, again, the quality of study seems to be adequate. She begins voiding at 12 centimeters, and then she completed voiding with a Qmax of 26 and voided 442 with a fairly low detrusor pressure. This is peculiar of females, particularly of the stress urinary incontinence, who have a fairly low outlet resistance, and therefore they seem to void at a low bladder pressure, low detrusor pressure, and a high flow. But of course, that does not give you a diagnosis of the incontinence. Diagnosis of incontinence is made essentially by demonstrating the leakage which occurs at a fairly low abdominal pressure, and that goes in favor of intrinsic sphincter deficiency, which is a significant element in the genesis of incontinence in this case. To give you the presenting picture, 57-year-old female presenting with urinary incontinence and coughing and sneezing for the past 6 months. She also had urgency incontinence, which is peculiar. Her clinical profile says that she has had 2 cesarean sections in the past. Ultrasound shows left ovarian hemorrhagic cyst. She had a POPQ score, this is what is shown, but she has a mild pelvic organ prolapse, but she has a patulous urethral opening. So urodynamic questions in this case are, does she have a pure stress urinary incontinence? Is there an element of urgency urinary incontinence? And finally, how is her voiding function? So let's get back here. Her urinary flow rate seems to be reasonably normal for a female of her age. So Qmax was 23 mL per second on a water volume 499. When it comes to pressure flow study, this is what we found. Now, quality control has been established. Now what we see is when you start the filling, there is some amount of detrusor overactivity here and overactivity here, both producing urgency as well as leakage, which is documented on the uroflowmeter. So these are 2 episodes of detrusor overactivity producing leakage and producing symptoms of urgency as well. When it comes to leak point pressure measurement, when you look at that, she has abdominal leak point pressure of 57 centimeters, which is fairly low by any standards, probably an element of ISD. And when it comes to voiding, you find that the cuff impulses are subtracted properly. She has a slightly high voiding pressure, but again, there is a erroneous drop in rectal pressure to about -7 from +8. So about 15 centimeters drop. So this has to be corrected here. So actually voiding pressure may be around 30 centimeters of water. And for a female, this is reasonably normal with a peak flow rate of 90 ml per second. She voided a total amount of 348. Cuff impulses confirm normal signal input. So basically, this woman has urgency urinary incontinence because of detrusor overactivity. She has stress urinary incontinence because of ISD, and she has a normal voiding pattern. When it comes to conclusion here, what we have said is this is a hypersensitive bladder with moderate degree detrusor overactivity, which can explain her presenting symptoms of increased urinary frequency and urgency, as well as urinary incontinence, which is of urgency type. She also has a significant element of stress urinary incontinence. The low abdominal leak point pressure suggests a weak sphincter function, ISD. Voiding is clearly unobstructed. In conclusion, this is a case of mixed urinary incontinence with urgency as the predominant element. A female age 35 years, she presented with urinary incontinence and coughing and sneezing for the past 3 years. She also has increased urinary frequency, urgency, and incontinence. Clinical profile, she has had 2 full-term normal deliveries in the past. She had chikungunya 10 years back. Physical examination shows neurological examination has an intact sacral reflex arc. So, urodynamic questions in her case, does she have a pure stress urinary incontinence? Is there an element of urgency urinary incontinence? And is this a mixed urinary incontinence. This is what we want to find out. Now, let us look at the flow rate. She has a Qmax of 39, water volume of 230 ms is a normal flow for a female. Let's go to her pressure flow study, and that is where it becomes quite interesting. In a flow rate, you find the pressure subtraction seems to be good in all the cases, but what happens here is something to be looked at. When she gives a large cough, there is no leakage, but leakage occurs immediately after when she throws a detrusor contraction. Another point of leakage when it has a higher detrusor contraction. Okay, and similarly here. So the leakage is because of the detrusor contraction when she had a sensation of urgency, but this detrusor contraction is induced by coughing. So it's cough induced detrusor overactivity, is also called in the popular terms cough associated detrusor overactivity, CADO, producing incontinence. The point of interest in this case is, although cough was responsible for inducing incontinence, this is not a case of pure stress leakage. Besides, this is a case of urgency incontinence, although urgency is induced by cough. With the cough induced detrusor overactivity producing incontinence, and therefore just gives you an idea that this can actually give you an erroneous idea of stress urinary incontinence. But urodynamics has showed clearly that this is a detrusor overactivity incontinence induced by cough, and therefore she will not be managed by surgery, but she has to have a pharmacological management and physical measures to control detrusor overactivity in order to relieve her symptoms.